called TTP. 30 years later, Gasser described renal failure, thrombocytopenia, and microangiopathic anemia, and that was called hemolytic uremic syndrome. During the 1980s and the late 1990s, a controversy arose. Were these two different diseases, or was it part of a spectrum? And today, I think that question has more or less been resolved. We talk about the thrombotic microangiopathies to represent a group of diseases which have microangiopathic anemia, thrombocytopenia, and a pathology of occlusion of small vessels by thrombi. There are two such conditions, and we know today that they are distinct, TTP and HUS. They are both rare conditions. The commonest of them all, which is seen in both adults and children, that is sugar toxin E. coli HUS, has a frequency of 2 to 6 per 1 lakh population, and the atypical forms of hemolytic uremic syndrome are about 10 to 20 times less common, being 2 to 3 per million population. Importantly, though we are interested in the kidneys, this disease can affect the central nervous system, the heart, the gastrointestinal tract, and the pancreas. And today, fortunately, death has fallen from where it used to be about 70% earlier to less than 5%. Now, the first attempt at really understanding and classifying the thrombotic microangiopathies came from the European Pediatric Nephrology Study Group in 2006 from this article, where they divided them into two groups, those where the etiology was fairly well known, and they included in that the disorders of complement regulation. So we knew that complement dysregulation was responsible for some of these disorders. There was also a deficiency of the 1-Willebrand cleaving proteinase, that was what was called ADMTS13, and there was of course the sugar toxin producing E. coli and some metabolic and drug induced disorders. There was also a group of diseases in which there was a strong association between various etiological factors and what was then the thrombotic microangiopathy, and they call these clinical associations, but etiology wasn't proven. Today, our understanding is a little different. Those group which Besbus called the etiology known, we know have mainly a genetic predisposition, and this group, as I'll show you in a minute, are mostly the triggers. So we have a two-hit theory today. We have a patient who has a genetic susceptibility and a second hit, which is a trigger, which produces the clinical syndrome. Now, this is the current classification, and it appeared in 2014 from James George and Carla Nestor. What it says is, the word here used is thrombotic microangiopathies, indicating that the whole group of diseases has thrombotic microangiopathy as a common thread. If you have TTP, then you have homozygous or compound heterozygous mutations in ADMTS13, and the treatment is plasma infusion. You have complement mediated, so dysregulation of the alternative complement pathway, and you have mutations in various complement genes. You have metabolism mediated, which is the rarest perhaps, which is in cobalamin C, the gene for cobalamin C, and you have the coagulation mediated group. So you have homozygous mutations in diacylglycerol kinase, plasminogen, and thrombomodulin. Now you have a group of disorders which could be either drug mediated, infection mediated, or autoimmune. So you could have autoantibodies which inhibit ADMTS13, or autoantibodies which inhibit the complement factor H, which is a regulatory protein in the complement pathway, and produce a clinical phenotype which is identical to that seen with the genetic disorders. Over the last 15 years, we have seen about 120 cases of these disorders at the KEM hospital, and 72 of these were in adults, and the large majority of them occurred in the peripartum period, as I will show you, followed by vasculotoxic snake bite, and the complement gene mutations, we've only started picking them recently as we studied them, is a smallish group. In children, we've had 48 patients, and this graph is really changing as I go along. A large group, which I would have called idiopathic a few years ago, we now know is caused by anti-factor H antibodies. And in India, this appears to be the commonest form of atypical hemolytic uremic syndrome. And as we test for it, this number is growing. So it's almost half over here now. And we do have some small numbers of DAGKE and ADMTS13 mutations in some of our patients. Central to the pathogenesis of the atypical hemolytic syndrome is a disorder of the complement pathways. Now, complement is activated, the complement activation occurs by three pathways: the classical pathway, the lectin pathway, and the alternative pathway. The alternative pathway is in a continuous state of low level activation, which is called the tick over, it's called the tick over, in which complement factor C3 is continuously converted to C3b. The C3b then binds to C3 convertases and further forms more C3b, and in this situation the C3 convertases therefore will feed back on C3, converting it to C3b. So we have a self-amplification loop over here, leading to more and more generation of C3 convertases and more consumption of C3. If this pathway were not regulated, there would be the C3 convertase would then act on the next step in the pathway. It would act on C5. It would break this down to C5a and C5b. C5 would activate C6, C7, C8, C9, and ultimately it would form what is known as C5 to C9, the membrane attack complex. Now, the purpose of formation of the membrane attack complex is to opsonize bacteria, lead to their phagocytosis, and therefore destruction of infectious agents. But if this pathway is already in a state of tick over, then it needs to be regulated, and that is done in two ways. In the fluid, that's the plasma, by complement factor H, and at the cell surface, the endothelial cell surface, by membrane cofactor protein. Complement factor H is a regulatory protein which is able to bind C3b and lead to its then being cleaved by a serine protease CFI, complement factor I, into inactive C3b. This is what happens in the normal situation. We saw that C3b is formed by the action of C3 convertases. Complement factor H can bind C3b both in the fluid phase in plasma, and it can also bind it at the endothelial cell surface, where it is helped by another protein, CD46 or membrane cofactor protein. Once these two, C3b, CFH and membrane cofactor protein, bind C3b, it is inactivated by factor I. In the absence of or inability of CFH, CFI or membrane cofactor protein to act, this is what happens. You have unlimited activity of the C3 convertases, formation of C5 or action on C5, conversion to C5b, C5b to C9, the membrane attack complex. The endothelial cell membrane is destroyed. It leads to the liberation of these large von Willebrand factor multimers, which are released from the viable palate bodies. There is destruction of the endothelium, exposure of the subendothelial layer, platelet aggregation takes place, platelet-rich thrombi are formed on the endothelial surface and on the subendothelial structures. This leads to microthrombi formed, and as the RBCs pass through these obstructed blood vessels, they are fragmented mechanically, leading to the classical cystocytes, which are then seen on the peripheral blood smear. So this is what happens. You have an amplification loop in the absence of factor H, which leads to the activation of complement factor 5, formation of the membrane membrane attack complex with hemolysis, inflammation, thrombosis, and tissue damage. If it occurs in the kidney, this is the hemolytic uremic syndrome. If it attacks other organs, well, that is what people thought was TTP when the central nervous system was involved in this situation. And we have also now seen the intestine, the heart, and the pancreas can be affected in this loop. Our understanding of the role of the complement pathway in this disorder has led actually to the design of a monoclonal antibody called Eculizumab, and I'll mention it as we come to the treatment, which inhibits the action of the conversion of C5 to the membrane membrane attack complex. So this is a good example of how understanding of the pathophysiology has led to the development of a specific drug which is active in this condition. There is some similarity between activation of the complement pathway, which leads to on the cell surfaces, which leads to the thrombotic microangiopathies, and in the fluid phase where immune complexes form, deposit in the glomerulus, and that is the pathophysiology of the condition we today know as C3 glomerulopathies. More about that as we go along. I said earlier that there is a genetic susceptibility, and today several of the genes which are involved in the whose mutations are involved in the development of the thrombotic microangiopathies called hemolytic uremic syndrome have been studied. The commonest of them all worldwide is supposed to be complement factor H, with multiple mutations having been described. Around 1/4 to 1/3 of all these disorders are linked to mutations in complement factor H, and the prognosis is poor if untreated, and there is a high recurrence rate in a kidney transplant because complement factor H is synthesized in the liver. There is also sometimes the formation of a hybrid gene between complement factor H and a group of genes which lie just upstream of complement factor H. Their role today in their role in the modern complement pathway is not very well understood, and so they are called complement factor H related genes and are numbered from 1 to 5. If a hybrid gene forms between complement factor H and one of the complement factor H related genes, we have a non-allelic homologous recombination with an inability of factor H to perform its normal function, and also leads to the phenotype of thrombotic microangiopathy. We also have, and I'm going to come to this because this appears to be the most common mutation in Indian patients, mutations in complement factor H related proteins 1 and 3, and that is, though it's reported in the Western world as 5 to 10% with an ESRD rate of 30 to 40%, we have found this to be present in more patients than any other. CD46, membrane cofactor protein, and complement factor I. These are all loss of function mutations. We also have gain of function mutations in C3, which leads to self-amplification, complement factor B, which activates the C3 convertase, and these have a poor prognosis also. So much for the complement pathway. In the last 7 or 8 years, a group of disorders which have a clinical phenotype of thrombotic microangiopathy have been described, but in which the complement pathway was not involved. Rather, intracellular proteins like diacylglycerol kinase have been involved, and this has been described very recently. There are about 30 to 40 case reports in the world literature. It's seen almost exclusively by a presentation in the first year of life and the development of repeated episodes of thrombotic microangiopathy of the kidney with end-stage renal disease by the second decade, or another intracellular protein, thrombomodulin, which has also been involved. It would be nice if we could thus slot all our patients into these two groups. However, there have been reports of where both the complement pathway and the DAG-KE genes have been involved, and there are a small number of case reports on this, around 5 in the world literature, but we have seen 2 such patients in the last 1 year. This is complement factor H. It is composed of about 20 small subunits called short consensus repeats, which are numbered from 1 to 20. The amino terminus of the protein is here at 1, and it is responsible for the cofactor activity with complement factor I, and it is therefore important in the serum. While the carboxy terminus is located here, short consensus repeats 16 to 20, and this is responsible for surface binding, where it is responsible for endothelial protection. As you can see, and I'm not going to list, you can see most of the mutations, and over 100 have been described today of these mutations. You can go to www.fh hus.org. It's continuously being updated. But most of the mutations which are responsible for HUS are located in short consensus repeats 16 to 20 at the carboxy terminus of the protein. 2 types of mutations may occur. those associated with a quantitative drop in factor H levels in the serum and could be homozygous or heterozygous, and those in which there is a dysfunctional protein but a normal level of the protein in the serum. Also described a group of conditions with single nucleotide polymorphisms. Their exact role today is not quite known, as I will show you from one Spanish study. Importantly, all of the mutations will result in a genetic susceptibility, but a second hit in childhood or adults is required to trigger the disease. And we have a whole lot of triggering factors: non-sugar toxin diarrheal illnesses in susceptible patients, non-enteric infections, most notably Streptococcus pneumoniae, viruses, a whole lot of drugs of which are known for ourselves, cyclosporin, tacrolimus, bevacizumab are the common ones. Oral contraceptive pills, quinine used to be used a lot earlier, autoimmune phenomena, pregnancy. 10 to 15% of all female patients who get this condition. Snake venom, common in India, as I'll show you in some of the studies, and there's still a large group of triggers which are probably unidentified and today have still been labeled as idiopathic. There is some limitation to the genetic studies, as you can see from these two studies which were published in the Kidney International some years ago. In this series of 141 patients, more than half no mutation was found. In the French study, again, about half no mutation found, but the clinical phenotype existed. And when we in 2008 sent 8 samples of our patients to be analyzed, a mutation could not be found in 6 of them. At that time, Sanger sequencing used to have a long turnaround time. This is a breakthrough paper which came from the All India Institute of Medical Sciences and was published in the Kidney International about 3 years ago. They studied 246 patients from 26 centers across India and found that, as opposed to the Western world, where 5 to 10% of all the thrombotic microangiopathies had anti-factor H antibodies, in India it was more than 50%. About 56 to 57%. There was prolonged oligoanuria in these patients, low levels of hemoglobin, platelets, and C3, a relapsing course, and there was no correlation between the anti-factor H antibody titers and the factor H levels. When these patients were treated in different ways, what they found was that early treatment with plasma exchange and combined with immunosuppression resulted in a very excellent improvement in these patients as compared to those who received supportive treatment alone. And continuing the immunosuppression as maintenance therapy over several months to 1 year, which is the current recommendation, resulted in the best prognosis overall. When these patients whom they found, then they analyzed them for genetic mutations, look what they found. The homozygous deletion of CFH-R1 and R3 was by far the commonest, 82%. And when they looked at other deletions in these two genes, the total number of the patients with anti-factor H antibody disease numbered almost 89 to 90%. When they looked at the controls in their series, what they found was, once again, you had only about a normal CFH-R1 and R3 in about 55% of patients. So a huge number of our Indian patients appear to have CFH-R3, R1, R3 abnormalities in their genetic sequencing. This is what I looked at a number of studies of anti-factor H antibodies. The AIM study is there, our own KEM data is there. What you find is it's a disease mainly of children. It's a relapsing course in most situations. When you look at the percentage, in the Western studies, it's small, and in Indian studies, it's much larger. The age at onset in the AIM study was about 8 years, as opposed to the genetic disorders which generally present in less than 3 years of age. And the composite of death and end-stage renal disease is unfortunately still high at almost 1/3 to half of the patients. I have a strong feeling that this is going to improve, as the AIM study has stressed the importance of combined plasma exchange and immunosuppression, which has now become a part of the guidelines which were issued by the International Pediatric Nephrology Society in 2016. This is the editorial that appeared in the Kidney International based on the AIM study. What it said was the anti-factor H antibody titers correlated inversely with C3 levels. If they were able to be decreased to less than 1,000 units with treatment, the prognosis was good. If the titers were more than 2000, there was a risk of relapse. Low C3 in the acute phase and a delay in initiating therapy were associated with adverse outcomes, and maintenance immunosuppression would reduce the risk of relapses from about 30% to less than 10%. So a word about testing for anti-factor H antibodies, something that we have been doing for the last 3 years. We use an ELISA technique to test. The ELISA results as given by the manufacturer are expressed in arbitrary units based on cutoffs for positive and negative control, with normal values having to be obtained for each population studied. When we began to test, we used healthy blood donors, school children for general checkups, and patients with other diseases other than thrombotic microangiopathy admitted to our wards. What we found was that the normal range was about 0 to 20 in our hands. There was a linearity in the optical density ELISA readings between readings of 1 and 2.5, whereas above 2.5 they tended to cluster and give false low readings. So we needed to dilute samples if the ELISA reading was more than 2.5 prior to reading. This technique detects only free antibodies, not complexes. So there is a false low reading once again if the anti-factor H antibody is tightly bound to factor H. And in this situation, what we have been doing is to dissociate it using 4 molar sodium chloride. False negatives will occur naturally after plasma infusion because that supplies factor H, and there is a need for validation against standard methods of commercial ELISAs, and there is a need for standardization of the technique wherever it's being used. When we looked at titers in various conditions, what we found was the highest titers came during relapses, severe relapses, followed by acute phase. They tended to drop in remission and sometimes rose subsequently without a clinical illness, but they were always much higher than controls. And when we looked at a group of patients who had C3 glomerulopathy, we found much lower levels of antibodies. Now, this could be because we didn't see the C3 glomerulopathy patients in the most acute phase. They generally came to us after their disease had been treated outside and they were not in and were not responding to treatment. So we tended to pick up their samples late. If we pick them up early, perhaps we'll get higher titers. Our median value was about 5 times the upper limit of normal with C3 glomerulopathy. Why does the same antibody, anti-factor H antibodies, sometimes produce glomerular nephritis and sometimes produce a thrombotic microangiopathy? Some of the answers to this may be found in this study by Caroline Blanc, which was published 2 years ago. She compared 17 patients with C3 glomerulopathy and 19 patients with atypical HUS. Although the titers were about twice as high in patients with HUS, she did not find this was statistically significant, perhaps because of small numbers, but she found antibodies from glomerulonephritis patients possessed a weaker interaction with factor H. They did not form circulating immune complexes. They bound to the N-terminal, the amino-terminal portion versus the carboxy-terminal portion of factor H, and they resulted in a fluid phase dysregulation rather than the cell surface dysregulation needed for HUS. Now, this is what happened when she added sodium chloride at increasing molar strength to the solution. The antibody binding with factor H tended with HUS tended to be stronger than that with the antibodies found in C3 glomerulopathy. When she looked at immune complexes, they were markedly higher in HUS as compared to C3 glomerulopathy, which was only marginally above that of the controls. And when she used the sheep RBC hemolysis assay, again, the hemolysis produced by healthy controls and that produced by C3 glomerulopathy antibodies was only slightly higher, but it was very much higher when she looked at the antibodies found in the HUS patients. Now, when we looked at that, we also could determine, when we looked at sheep RBC hemolysis, we also could determine that even within our subgroup of patients who had HUS secondary to anti-factor H antibodies, there appeared to be a qualitative difference in the antibodies. This patient had a severe relapsing course, 7 times relapsed in the course of a year and a half, and his antibody titer is around 811, but it produces severe sheep RBC hemolysis. Whereas this patient, whose titer is almost 10 times higher, doesn't produce quite the same degree of lysis, though his antibody titer is almost 8,000. So there appears to be a difference qualitatively among the antibodies found in against factor H, and this will require further elucidation. There is now a standardization among 3 laboratories in Europe, all reference laboratories, which recommend that the Paris method for anti-factor H antibody testing should be used. Samples should be diluted 1:50. The ELISA may produce reasonable results, but it tends to cluster at the higher values, and there is necessity for an international standard for all these assays in order to know what is the true nature and content of these antibodies. And any labs, we need to do this in our country. We need to have more labs doing the testing, and all the labs need to standardize the assay. This is how we do the SHIP RBC lysis test. A plasma sample is added to a veronal buffer, EGTA buffer, along with 100 microliters of SHIP RBCs. It is incubated at 37 degrees with gentle agitation for half an hour. The reaction is stopped with 1 ml of ice cold veronal EDTA buffer, centrifuged and read in the spectrophotometer at 419 nanometers. We simultaneously prepare a control with total lysis produced by distilled water and a blank in which the RBCs are not added. We looked at the RBC lysis assay in 13 patients who had atypical hemolytic uremic syndrome. All of them had hemolysis much above that of the control patients who were healthy blood donors in our blood bank. We also found that the RBC lysis was highest during the acute phase, and in the same patient it tended to drop when the patient was convalescent. As we can see here, this is 4 patients in whom we looked at, and again it tended to rise during a relapse. So probably this could have been because of variation in the values of anti-factor H antibodies, but when we first started doing this, we did not know that that was what we were dealing with. What we were looking at was the disease activity was preceded by an increase in the lytic ability of the patient's serum for SHIP RBCs. The lysis could be inhibited by adding control plasma. So here you have the therapeutic, and that also differed depending on the patients, indicating that there was probably a difference in the amount of control plasma that needed to be added to inhibit this reaction. And what is the value of the RBC lysis assay? This is data from a Spanish study which picked up 2 single nucleotide polymorphisms and wanted to know whether they were any different in their clinical significance from the wild type in which there was no polymorphism. When they looked at the lysis produced by a control serum known to have lytic activity and thrombotic microangiopathy and added the test serums, all the test serums, those of the wild type and those of the variants, inhibited the lytic activity of the control equally rapidly with just about 2 to 3 micrograms of the defect of the mutant factor H as well as the wild type factor H. This meant that although a single nucleotide polymorphism had been uncovered, it was not pathogenic, but what was called as a variant of unknown significance, and therefore what we have is a reliable functional assay to tell us what is the possible pathogenetic significance of a mutation which has been discovered. I'm going to look at one of the specific triggers which is important in our Indian patients, and that is snake venom. Snake venom induced thrombotic microangiopathies have been described since the 1980s from various centers. A study of 24 patients from CMC Vellore. There were studies from PGI Chandigarh. I'm going to look at 18 patients whom we have studied in the last 10 years or so. 2 were children, 16 were adults. 17 of them had thrombocytopenia. All 18 were dialysis dependent. The complete triad of thrombotic microangiopathy was found in 14 and extrarenal manifestations in 4. When we began to test for C3, 5 out of the 7 samples that we tested had low C3 values. The patients responded well to plasma infusions or plasma exchanges. We did a biopsy in 3 patients and we found cortical necrosis in 1, and 3 patients had a low GFR at follow-up. 2 patients came to us for follow-up, and we collected their convalescent samples of serum and then tested this with the SHIP RBC lysis assay, and we found that these patients had a defective factor H probably. We haven't been able to do mutation studies, but even in the convalescent phase, their serum had more lytic activity than healthy controls. This is a study from Srinagar which looked at 360 patients of saw-scaled viper bite who developed, of which 1/6 developed AKI, and 1/5 of those had microangiopathic hemolytic anemia. The platelets were low in these 12. They were lower than the patients who had DIC, and the FTPs were negative. The clotting time was normal as opposed to those who had DIC, but the bleeding time was abnormal. Why does this happen? Well, Gabriel Tanaka and his group have identified a factor in venom called cobra venom factor, which contains a C3-like molecule. It initiates alternative pathway by forming a very stable C3-C5 convertase with factor B and results in activation of the complement cascade. What it does is to generate large amounts, and these are various microcurus snake venoms, which and shows you how much of C3A, C4A and C5A is generated by this snake venom in vitro. We look at the RBC hemolysis with microcurus venom. Once again, all the microcurus venom samples produce large degrees of hemolysis, indicating that microcurus venom and perhaps viper venom are able to activate the alternative pathway of complement in susceptible individuals. And there is even a recent article published in January this year of 2 cases reported from Chennai in which a similar condition has been noted with Russell's viper. When do we do genetic studies for susceptibility? Well, the International Society of Pediatric Nephrology guidelines say the first episode of HUS, if there is no evidence of enteropathogenic infection, there is no severe ADMTS13 deficiency, if there is a relapse, if there is a family history, in pregnancy and postpartum cases, in de novo or post-transplant cases, and before renal transplantation, because if we miss a genetic susceptibility here, we can expect that there would be a recurrence of the disease in the allograft kidney. We have tested a few patients, and this is what we found. The first 2 patients in this table are a brother and sister. The brother died in the acute phase at 14 months of age, and when we sequenced his gene, we found, surprisingly, though the clinical phenotype was of acute kidney injury, we found an ADMTS13 homozygous missense mutation. We found the similar mutation in the sister who had presented for the first time at 3 years of age in 2008. She then had, over 3 years, she had a relapsing course, was lost to follow-up, and returned to me last year as end-stage renal disease. And we could find that she had the same mutation. We've also found ADMTS13 mutation in one boy, a much older boy, but he also had CFH-R1, R3 homozygous deletions. And when we tested his stored samples, we found that he had very high titers of anti-factor H antibody. So I'm not sure whether this heterozygous mutation contributed or whether this was purely an anti-factor H antibody disease, since he responded extremely well to plasma exchange and immunosuppression. Now, this is a family which we have in our setup, in which several members over 3 generations all have chronic kidney disease. The index patient here underwent a transplant in an external hospital in 2012 and didn't do well. His creatinine steadily rose, and when he came to me last year, his creatinine was 5 and he underwent a renal biopsy. Now, his maternal aunt had been transplanted in KEM with an unknown disorder leading to chronic kidney disease, and her son was also discovered. So our index patient's cousin was suddenly found to also at the age of 21 have chronic kidney disease. He only had a vague history that at the age of 4 he had some nephritis. When this patient's allograft was biopsied, what we found was a thrombotic microangiopathy. We then went back to all the living family members and tested their C3 levels, and all of them were low. Now, the family here, the initials shown in blue, this is the group. We tested all of them by multiplex ligand probe analysis for complement gene disorders, and all of them had homozygous deletions in CFH-R1 and R3. That is, these 3. These 2 are cousins, and this is the aunt. She's undergone a transplant. This man has lost his transplant, and this patient has just been transplanted 3 months ago. Now, the patient whom the index patient's son, who was 14 years old and totally asymptomatic, also had low C3 levels, and what we found was a heterozygous deletion in this patient. So we're keeping a watch on that. This is another patient, a 40-year-old, who had a severe post-transplant TMA resistant to plasma exchange and is now back on dialysis. We did both 3rd generation sequencing and an MLPA in this patient. We found the gene sequencing was normal, but there was a copy number, abnormal number of copies in the CFH-R1, which resulted in heterozygous deletions in exons 3, 5, and 6, and in R3, and in both exons and introns. Finally, there are these two patients who presented in the first year of life. Interestingly, one of them actually had high anti-factor H antibodies. Both had low C3, but they didn't respond to plasma as well as we might have. And when we submitted them to gene sequencing tests, both of them had deletions, large deletions in the DAGKE gene. So, when presented with a patient with thrombotic microangiopathy, we need to look for triggers, we need to look for genetic susceptibility, and these are the triggers commonly studied. This is taken from the ISPN guidelines and from the KDIGO controversies guidelines published in the Kidney International in Jan this year. We need to ensure that every diarrhea is tested for sugar toxin producing E. coli. Diarrheal illness is not equal to HUS. If we have a suspicion of strep pneumoniae, the direct Coombs test as opposed to all other HUS will be positive. There are various other infections. And finally, if we have none of these triggers, we have an unknown condition, we have a post-transplant patient or a postpartum patient, we need to look for the complement gene mutations. How do we manage a patient with this disorder? Cartland in 2014 suggested this algorithm: screen the patient immediately, prove the thrombotic microangiopathy, start with plasma exchanges. If there's a good response, continue. Side by side, look for ADMTS13 activity. If it is low, treat as TTP. If it is more than 10%, look for complement mutations and consider shifting the patient to Eculizumab therapy. Now, Eculizumab is the treatment of choice, but it is not available in India officially. It has to be imported on compassionate grounds. The ISPN guidelines of 2016 state that Eculizumab should be the first-line treatment to avoid plasma exchange and the complications of central venous catheters. Confirmation of a complement mutation, importantly, is not required. Treatment initiation should be done immediately, as the undue delays could be deleterious. If Eculizumab is not available, plasma exchange or infusion should still be started pending that. So that's applicable to us in a big way. And plasma therapy is still the treatment of choice, perhaps, in anti-factor H antibody disease. In critically ill patients, since Eculizumab takes time, in patients in the ICUs with coma, convulsions, or where there is a strong presumptive diagnosis of TTP. The only urgent investigation required is anti-factor H antibody testing, and we can obtain the result in our hands in about 4 hours after the sample reaches the lab. Once we have a first episode, either Eculizumab or plasma exchange, we need to, if the patient is positive for anti-factor H antibodies, add immunosuppression to either of these therapies: steroids, mycophenolate, cyclophosphamide, or rituximab, or we have been using azathioprine equally successfully. Maintenance therapy is required, and we can stop the treatment after 1 year of stabilized remission, ensuring that there is an anti-factor H antibody less than 1,000. This is the KDIGO controversies guidelines. Plasma therapy, Eculizumab. Both could be used, but there has to be a simultaneous immunosuppression and periodic monitoring of anti-factor H antibody therapy. There's no definite guideline when to stop plasma or when to stop Eculizumab, but the immunosuppression can be discontinued when the antibody titer is non-pathogenic for 6 months. The definition of non-pathogenic may be dependent upon the setting in which the disorder is. What plasma exchange? Well, the 2009 guideline is recommended there. Daily sessions for 5 by 7 for 2 weeks, alternate days for 2 weeks, and then assess the outcome at day 33 is what the European guidelines say. If we are using plasma exchanges, the time to resolution of the clinical conditions are: neurological symptoms will resolve in 3 days, the LDH should be down to less than 500 in 5 days, thrombocytopenia may take 10 days, and renal function at any time after 15 days, going up to as much as 3 to 4 months. We have treated our patients and looked at their outcomes. The outcomes in children have been good. 65% of them were resolved completely. Hematological remission was achieved in 39 out of 44 patients, and we had death in a small group of patients in the acute phase, 12%, and we had end-stage renal disease in the first episode becoming dialysis dependent in another 9% of the patients. When we looked at adults, the outcomes were even better. 70% resolved completely. Death in the acute phase, however, was still seen in 17%. Many of these were catastrophic antiphospholipid syndrome with APLAS, and ESRD in 7%, and some of these patients actually weren't treated fully. When we looked at category-wise what was happening to these patients, what we found was
just
of the
to add to
total,
the complexity, I was in the Russia regional board yesterday, and this issue came up there as well. So here's another language for you.
Yeah. So what we had was autoantibody disorder, anti-factor H antibody associated disease seemed to do best of the lot, as well as those who had strep pneumonia. Actually, we missed the diagnosis in one of these. We didn't have T antigen or blood culture came late.
If the issue is translating the forms, I think it's a one-time job. So I think we could conceivably do it. But the question is going to be evaluating the applications.
The adult patients, again, the ones with catastrophic antiphospholipid did worst, and our group of peripartum patients actually did the best of all, with only one patient dying and only 3 becoming dialysis dependent out of 35 patients. There wasn't much difference between plasma exchanges or plasma infusions, but that could be because the most seriously ill patients got exchanges as opposed to infusions. Is plasma exchange perfectly safe? This is a 14-year-old patient who had high anti-factor H antibodies, and every time he had plasma exchange, he became hypoxic, had respiratory distress, and needed non-invasive ventilation, and his X-ray looked like this. This is transfusion-related acute lung injury, and it precludes it contraindicates the use of fresh frozen plasma. Now, fortunately, we did know that in this case, it was antibodies we wanted to remove, and that we could switch this patient, therefore, over to a plasma exchange, not using fresh frozen plasma, and add immunosuppression. And very fortunately, he did extremely well after that. So we have looked at 349 sessions of plasma exchange, and we've had 6 episodes of TRALI in the total of 120 patients. We've also had some other minor complications, mainly related to the central venous catheters. Where are we with Eculizumab today? There are 4 studies involving more than 80 patients today. The median treatment was about 26 weeks, with follow-up going up to 2 years in all these patients. They are very recent studies, 2015, 2016. And look at what happened in the deaths. Only 1 death across all these 4 studies, and the percentage of patients on dialysis less than 20%. So Eculizumab seems to offer these patients an extremely good outcome, normalization of the platelets in more than 90%, normal hematology, TMA-free event status on more than 90%, mean increases in the GFR which varied from 6 ml to 35 ml. But when can Eculizumab be stopped? Well, in adults, we don't really know. In a child who is more than 3 years of age with complete recovery of renal function, a minimal period of treatment, absence of extrarenal disease, we may stop. In a transplant recipient who has lost 1 allograft, perhaps Eculizumab cannot be stopped. So I showed you Catalan's algorithm which looked at Eculizumab. If we don't have Eculizumab, but we do know that a large number of our patients have antibodies, we would continue plasma exchange, add immunosuppression, and when would we stop? Perhaps there is a role for a renal biopsy before stopping. My last bit, can one transplant patients with complement dysregulated hemolytic uremic syndrome? Well, combined liver kidney transplant would take care of it, covered in the perioperative period with plasma exchange. Or if Eculizumab is available, then a kidney transplant alone with Eculizumab prophylaxis may be thought of. If there are anti-factor H antibodies combined with plasma exchange, high-dose steroids, and rituximab, this may be done. And if it's a CD46 mutation, then a kidney transplant without any special precautions, because the transplanted kidney has normal CD46. So if I had to summarize what I have talked to, thrombotic microangiopathy has diverse features. It requires 2 hits, a genetic susceptibility and a trigger. In India, we appear to have a predominance of anti-factor H antibody disease, but we also have a predominance of CFH-R1, R3 deletions, and in adults, this seems to produce a severe disease even without high antibody titers. We don't yet have Eculizumab, but I hope it would come to India soon, and then till that time, we will continue to use plasma manipulations and immunosuppression, and a liver kidney transplant may offer a solution. I close by acknowledging my microbiology team, which helps us with all the testing, my hematologist, my pathology colleague, Dr. Fadke, who is our genetist, who has been invaluable to us, my chief who introduced me to this disease, and my colleagues in the Department of Nephrology, and last of all, my patients. This girl in 2003 was the first child in whom I did plasma exchange. 1 year later, when this boy appeared, I thought I knew everything about plasma exchange. He went through 7 relapses, received 67 sessions of plasma exchange, 834 bags of plasma, vincristine, azathioprine, steroids, mycophenolate, cyclophosphamide, and rituximab, and nothing seemed to work until he suddenly went into a spontaneous remission, which has been maintained till today. That leaves me with the idea that we still have a lot to understand yet about the disease. Thank you.